Good afternoon, everyone. Thank you very much for joining us here at the Dementia Academy webinar. We'll be addressing system readiness for disease-modifying therapies in Alzheimer's disease today. So I'm Iracema Leroy. I'm professor in geriatric psychiatry at Trinity College Dublin in the School of Medicine and also in the Global Brain Health Institute. And I'll be joined by Dr. George Crowther, who's a consultant in old age liaison psychiatry with the Leeds and York Partnership Foundation Trust. So the objectives of the webinar today are firstly, to appreciate an approach to ascertaining the number of potentially eligible patients for disease-modifying therapies within a region, to also see the application of a framework to address system readiness to deliver disease-modifying therapies for Alzheimer's disease, and finally, to understand the motivations to accept disease-modifying therapies in the general public, including this idea of willingness to pay. And of course, the reason for this is because these medications are significantly more costly than anything we've had within the dementia sphere to date. So I hope you enjoy the webinar. So this is generally what we'll be doing. George will start off with giving us a background and introduction to the disease-modifying therapies in Alzheimer's disease with a focus on some of the recent trials. And then I'll jump in with some ideas about system readiness. And of course, since we're all figuring this out as we go along, it's new territory. I think the most important thing is that we have a nice discussion together at the end. May I please ask all of you to use your Q&A function at the bottom of your screen rather than popping questions into the chat, because this way we can manage the questions and ensure we don't get duplication. Thanks very much. And finally, we'll ask you to complete a feedback at the end of the session. That's very important for us. So now I'm going to hand you over to George, who will kickstart our program today.
So it is lovely to see you, and thank you very much for having me today. My name is George Crowther. I'm a consultant in old age liaison psychiatry in Leeds, and also I'm an academic consultant in old age liaison psychiatry. So we're going to have a bit of a think, obviously, about the sort of new sort of treatments available in dementia. And before Ira comes in to talk about system readiness, we're going to sort of have a bit of a think about the current state of play, sort of the sort of history leading into these new medications, and sort of have a look at the evidence base for them, and a bit of a think about the pros and cons of these medications. And then before we think about how they might sit into our existing systems. So I'm just trying to move my slides on. There we go. So just to sort of briefly sort of think about the history, what we've had to date and sort of recently. Acetylcholinesterase inhibitors have been around for around sort of 25 years now, and memantine for around about 23 years. And then there's been a large sort of pause really in any sort of novel sort of medications for use in dementia, and anything coming that's disease modifying. And obviously during that time, companies have been busy looking for new treatments, and but over those sort of the last 19 years, 99.7% of all RCTs into Alzheimer's disease have failed and sort of dropped along the wayside. There's been an awful lot of money spent, an awful lot of failures, but recently we've seen in the evidence base and sort of very highly publicised in the media our new wave of disease-modifying drugs that you know we sort of are starting to understand better and looking towards the horizon and thinking, is this going to change the landscape of how we're looking after our patients with dementia? Just before we kind of go into have a look at what those drugs are, let's have a bit of a think about sort of what's been, you know, the sort of rough treatments sort of approaches over these sort of 19 years of failed trials. So the systems we're sort of looking at generally is the amyloid cascade. I'll come onto a slide in that in a moment. But what this sort of initial sort of strategy was okay, can we sort of target sort of strategy one, blocking the development of the toxic amyloid beta by reducing enzymatic activity, and we had alpha and gamma secretase inhibitors, which surprise, surprise, given my previous study, weren't shown to be particularly effective. And next, in 1999, we had a sort of thought around sort of vaccination, amyloid beta vaccine, and reducing that sort of plaque load, but with lots of difficult side effects of aseptic meningoencephalitis and sort of very limited effects on cognitive improvement. But more recently, we've seen this sort of concept of passive immunization and our monoclonal antibodies sort of coming to the fore, all of which are complicatedly named, much to my dismay as someone who struggles with these sort of things. But at least we can all sort of relax with the MAB bit at the end for monoclonal antibodies. So what, and obviously they're not alone, and there's lots of drugs in development around in the sort of drug pipeline at the moment, around 130 or over 130 sort of different drugs sort of in development, sort of looking at varying systems. So this is a very active environment, and one that we really only see the sort of tip of when drugs kind of come to sort of clinical fore. So what is the system I sort of referred to earlier, this amyloid cascade? Well, sort of what we sort of see in Alzheimer's type dementia is we've kind of got amyloid plaques forming in the brain, which trigger an inflammatory response, are toxic to the brain, and later on we see disintegration of microtubules as tau aggregates get involved as well. Busy slide, I know, apologies, but sort of unpick it a little bit more, because this is where all our sort of new monoclonal antibodies therapies are acting. So what's happening with these amyloid plaques? Well, we sort of have in a healthy brain correctly folded proteins. As sort of disease progresses, these proteins effectively become misfolded, so partially first of all forming beta-rich oligomers, and then subsequently forming amyloid fibrils, and then onto amyloid plaques, all of which are toxic to the brain and sort of we believe will lead to some of the symptoms we see in neurodegeneration we see in Alzheimer's type dementia. And this is where these new drugs, these sort of anti-amyloid sort of therapies act upon. So we've got lecanemab acting on the amyloid fibrils, aducanumab, gantenerumab, and donanemab acting on the plaques and beta-rich oligomers. And that's where we're going to focus. But just before we sort of have a look at what those are, I'll just have a think about the sort of progression, because the pathology that's sort of going on sort of with this amyloid plaque formation is happening a long time before patients are symptomatic. So we're talking sort of years, perhaps tens of years, before symptoms arrive here. So, and we've got this red line that I've sort of highlighted here, which is our beta amyloid accumulation. So if we're using drugs that are targeting beta amyloid, then actually we want to be theoretically targeting patients as early as possible, and that becomes relevant when we're thinking about how we can practically using these drugs. So let's have a bit of a think about the studies and the drugs themselves. And we're going to talk about 4 studies, but we'll sort of actually really 2 of which are more relevant now. What's going to be sort of 3 Once Upon a Time. And in order, they are Engage and Emerge, which looked at aducanumab, Clarity AD, lecanemab, Graduate. Here I get sort of tricky with pronunciation, so apologies, but looking at gantenerumab and donanemab with Trailblazer. And although I've put them there in sort of into time order, I'm actually going to talk to them out of order, talking about the 2 that haven't gone so well first, and talking about the 2 that are perhaps more relevant to our kind of clinical practice second. And we'll go over the first 2 reasonably rapidly before we move on to the second 2. So Engage and Emerge, we've got aducanumab, which is a monoclonal antibody therapy targeting the N-terminus of the amyloid beta peptide. And so what we'll sort of have is amyloid plaques being bound to by this by the monoclonal antibody, and then sort of microglial cells coming along, recognizing those and reducing the amyloid burden in the brain. So theoretically, sort of reducing the amount of amyloid plaques that are present and improving symptoms. Aducanumab was very well publicized as being FDA approved for the treatment of Alzheimer's type dementia back in 2001, amidst much controversy and quite a lot of sort of noise surrounding that. Particular concerns with aducanumab were the high rates of side effect profile and the low sort of impact seen on clinical sort of improvement. And when that it had a sort of an accelerated approval within its FDA approval, but subsequently has never been approved in Europe and then subsequently not funded by insurance in the States, and has recently been discontinued in early 2024. So one of the, I suppose, early sort of drugs that came along sort of promised a bit of hope, but actually never really has sort of gone anywhere. Again, as out of sort of time order, we'll talk about gantenerumab, which, and so we'll go into this one in a little bit more detail, but this is a sort of 27-month randomized controlled trial. And the difference here of this drug compared to sort of lecanemab that we'll kind of come on to is that this is a subcut sort of drug rather than infusion, given every 3 months, and then and given at 9 months and 2 weekly at 9 months. And this trial, large trial, 980 patients in each in graduate 1 and 980 in graduate 2, all with mild Alzheimer's type dementia or prodromal Alzheimer's type dementia, which had amyloid positive CSF or amyloid positive on PET scanning. And as I say, relatively mild disease with MMSEs of greater than 22 or clinical dementia rating scales of over 0.5 or 1. And what they showed in this trial was good amyloid clearance from the sort of from within the brain on sort of PET scan and CSF, but no evidence of any clinical difference of CDR decline at week 116. And no significant and a non-significant trends towards clinical effect reduction across the studies. So essentially, what was showed was good clearance, but no real sort of significant effect that can translate into patient care. So let's look onto something a little bit more hopeful with Clarity AD and lecanemab, which has been so you'll have sort of seen in the news with sort of recent MRHA approval in the UK, but which was not nice approved in sort of recent months. So lecanemab targets amyloid beta profibrils. So if you think back to that sort of slide I had earlier with the profibrils, which is the sort of third box along, lecanemab focuses there, which is one of the sort of more toxic forms of amyloid. And if we look at the sort of headline news from it, we'll sort of see advertised lecanemab could slow the rate of disease progression by 2.5 to 3.1 years and help people remain in the earlier stage of the disease for longer. But we need to drill down into more detail and have a think about, well, what does actually that mean for our patients and our system? So let's have a look at sort of what the design of the trial was sort of briefly. Clearly, we've not got time to unpick it in any sort of great deal, but we've got a placebo-controlled double-blind parallel group RCT, which is phase 3, with a good number of patients, so nearly 1,800 patients with early Alzheimer's disease in sites across North America, Europe, and Asia, randomized 1-to-1 into either placebo group or to receive lecanemab intravenously. And these are all patients who have had positive sort of evidence of amyloid on CFS or amyloid PET. And the primary endpoint was looking at clinical dementia rating sort of scale and amyloid burden and ADAS-Cog. So we see a slightly blurry sort of graphs, but the lecanemab sort of groups are in yellow and placebo in blue. And if you look at that sort of primary endpoint, we've got our clinical dementia rating scale, which is an 18-point scale, and we're looking at a sort of change from baseline over an 18-month period here in this sort of top graph. And sort of on first glance, it looks highly significant. It looks like those two lines are kind of nicely wide apart. But when we look at that in some more detail out of this sort of 18-point scale, what does that really represent? Well, that represents around about a sort of 0.45% difference between placebo and lecanemab over that 18-month period. So then you say, well, yes, they're statistically significant, and there is definitely a difference between those two groups. But how does that translate to patients and improved sort of everyday symptoms? If we look at what it's sort of doing within the brain, clearly having a pretty significant effect in this sort of graph B, where we've got our placebo with amyloid burden on PET starting off and staying high, and lecanemab group sort of with amyloid being kind of cleared, and a significantly sort of very wide margin between those two. But again, if we look at another sort of endpoint, looking at ADAS-Cog 14, so again out of 14 as it says on the tin, we do see lecanemab in this sort of yellow line outperforming placebo, but again by only sort of around 1.5 points over that sort of 18-month period. So how does that translate? Well, that sort of translates to a 27% reduction in clinical decline versus placebo at 18 months, and a 37%, if we look at activities of daily living, which they did, it's 37% slowing in clinical progression on activities of daily living, so 2 points less with lecanemab compared to placebo. And the ADAS-Cog, the 26% slowing we've already talked about, and amyloid biomarkers clearly being sort of a clear reduction there. But is this clinically meaningful? That's the sort of question there for our patient group. Is that sort of 0.45-ish percent drop on CDR actually meaningful to patients? There's an awful lot of pre-work up here in people sort of coming in pre-treatment. So all of these patients in the trial and everyone having this treatment will need to have had either CSF evidence of amyloid or amyloid PET prior to treatment. Practicalities of treatment delivery. This is an intravenous drug, and most of our memory clinics in the UK are not set up or anywhere near set up to sort of deliver intravenous treatment. Also, we've got to think about cost at around about sort of a course of treatment being around sort of £20,000 here, and follow up with regular MRIs because of the side effect profile here of ARIA, so amyloid-related imaging abnormalities causing encephalitis, of which in this trial there was an ARIA rate of around sort of 10%, and a mortality of 0.2%. And although most of those were asymptomatic, still pretty significant. And we'll go into ARIAs in more detail in just a moment. And then we kind of move on to donanemab with the Trailblazer sort of trial. This is sort of similar sort of theory from drug delivery, another intravenous agent targeting amyloid beta, a sort of priglutamate form of amyloid beta aggregated in amyloid plaques. Design quite similar. But the sort of big difference really in our sort of design here is that with the Trailblazer trial, the duration of people's treatment was determined by cerebral plaque load. So once people were determined to have had a significant sort of clearage of amyloid plaques, treatment stopped. So as a consequence, 52% of people in the trial sort finished at sort of 12 months, and a further 20% completed at 18 months. So that was that sort of end point, so a bit of a difference there. But again, intravenous infusion sort of drug. What are our endpoints? Again, so lots of graphs here to have a bit of a look through, come straight up. But our primary endpoint, here we've got the Alzheimer's Dementia Rating Scale. We've seen a sort of 32% slowing of disease progression over that sort of 76 week sort of period. Of course, significant, but actually a relatively sort of small change in that sort of baseline once we sort of unpick the scale. And we see the same with the clinical dementia rating scale. Remembering this is sort of we're out of 18 in the CDR-SB, which sort of and ADAS-Cog, again, only a sort of small effect size, and again, so reflects again an MMSE. But when we have a look, sort of similarly to lecanemab at amyloid clearance, we see sort of a very wide difference between sort of placebo to the donanemab. So what do we sort of see? In summary, we see a 40% less decline in activity of daily living over that 18-month period, 39% lower risk of progressing to the next stage of the disease on the ADAS-Cog. And in addition, sort of just to sort of talk about with donanemab, they saw a greater treatment effect in people with lower tau burdens. So if you had a higher sort of presence of tau, less sort of treatment effect sort of through the trial. But again, is this clinically meaningful? It's all the kind of graphs look very good, they look interesting, and we can sort of see our error bars and go, oh, absolutely, I understand that there's a difference, and this needs to be it needs to be better with our treatment agent. But is it clinically meaningful? Does that sort of small difference make a difference to our patients? Again, we've kind of got our difficulties with pre-diagnostic sort of testing before treatment with amyloid PET or CFS, which many clinics aren't set up for. And the practicality of drug delivery and cost like to be higher cost here than with the lecanemab, around sort of £25,000. And again, sort of follow up with MRIs and side effects with 25%. So 1 in 4 people in that Trailblazer trial experiencing ARIA, 5% of whom were symptomatic. So I've mentioned ARIA a few times, so let's sort of have a little bit of a focus on that before we sort of close up and I pass you over to Ira. So ARIA, I've talked about a couple of times, are amyloid-related imaging abnormalities. Essentially, we've kind of got sort of, again, if we're just going back to those sort of figures I was talking about before, but around sort of 10% with lecanemab, and donanemab sort of around sort of 25% patients experiencing ARIA, often asymptomatic, and it's sort of during the sort of treatment. So what we're having there is edema and sulcal effusions, and then ARIA-H, where we've kind of got hemides and sort of deposits as well, which are likely more dangerous and more likely to happen in people on anticoagulation therapy. And this has serious implications from a cost point of view and a sort of practicality point of view in monitoring this, because people will need regular MRIs after and during the sort of treatment course. And also it sort of poses a pretty significant sort of side effect risk as well for our patient group. Who are at risk? Well, as I say, most cases are asymptomatic. A few are serious and very few are fatal, but needs monitoring. Anticoagulation increases the risk of hemorrhagic sort of ARIA, so we'll have to be very sort of cautious of our patients who are on anticoagulants. But at the moment, the guidance would be that patients on anticoagulants shouldn't receive this, which actually is a kind of huge number of people in the kind of in those with dementia when we think about comorbidities. Also, people who are apoprotein E4 gene carriers seem to be especially at risk of ARIA, particularly if they're homozygous. So we need to also be having our systems ready to manage side effects and to really understand how we monitor that and how we care for people who are experiencing side effects as well. So in conclusion, sort of where are we and what have we got? Well, we've got some drugs that look promising, but what's the sort of clinically meaningful sort of treatment effect? What's the how are we set up to monitor people and sort of set people up for these drugs with CSF and sort of testing and PET scanning? How can we deliver these drugs in the UK? How can we manage their side effects? And how can we afford it? And then afford to monitor them going forward as well. As we know, as I mentioned earlier, MHRA have approved both lecanemab and donanemab, but NICE haven't. NICE stating most of these reasons I've sort of just gone through here, as the sort of reasons why, and further sort of research is needed beyond the data that we've already got, looking at the long-term impact of these. But I think the thing we need to think about, these drugs are probably the first stepping stones into monoclonal antibodies. And while we can pick up multiple areas of concern, multiple areas of reasons why these are going to be tricky drugs at the moment to manage, there are lots in development, and they're only likely to get cheaper. They're only likely to get easier to deliver, and they're only likely to get safer if we look at how drug development generally works. So we as clinicians need to be in a space where we're understanding these drugs well, we're understanding what the future is potentially going to be looking at, and we're going to be, and we need to be in a position where we're ready for them. At this point, I'll hand it back over to Ira and stop sharing my screen.
So I'm going to focus a little bit about system preparedness, because the thing that George was highlighted throughout was, what is the meaningfulness of the findings? And if we find them meaningful, how can we implement them? NICE is very clear. Based on the economic modelling, they felt that it is not cost effective at this stage to be introducing them into the NHS, keeping in mind that there are different systems available across the world, across Europe, and even within the UK, if you think about private versus public systems. So I'm going to touch on some ideas. Now, we don't have many solutions at this stage because, as I mentioned when we kicked off, we're all trying to figure this out as we go. But I hope that this discussion will incite some thoughts about how to move forward. And I've based my talk about 5 papers, which I'll touch on as we go. So just to mention, I work within the Global Brain Health Institute, and our goal is to reduce the scale and impact of dementia worldwide through a leadership fellowship training program, which is based in Ireland, in Dublin, and at the University of California, San Francisco. So entering the post-Donepezil era, I think with the approval of lecanemab and donanemab with the MHRA, and lecanemab more recently in Europe as well, we can comfortably say we're moved into the post-Donepezil era. And that, by the way, is a hippocampus, just in case anybody had any doubts. So the first thing I'm going to do is share with you this study, because we have very little real-life experience to date. Everything you've heard about has been from clinical trials, and we all know that clinical trials are atypical populations, and therefore the degree to which we can extrapolate that into our clinical settings is somewhat limited. But the papers are starting to emerge, and I think this one is quite helpful because it's about the lessons learned from the first 71 patients in a regional medical center in the States. And what did they find? So I'll go through these. It's a little bit dry, but I do think it's helpful because it can give us some comparative thinking along these lines. The mean age of patients was 72. And as you can see there, the range went all the way up to 90 years old. So I think that's an important finding. Most patients were male. That's not surprising. Most were Caucasian, and I think that is interesting considering this is an American sample, because one of the big debates about these medications is to do with equity and access to drugs, particularly in the face of the cost of the medication and the infrastructure needed to deliver them. This doesn't count only within certain populations within a health ecosystem, the UK, the USA, Europe, for example, but also globally. And it's important that we keep that in mind. The other thing that was interesting, of course, are the comorbidities. Comorbidities were common. That's not unexpected in this particular population, considering the risk factors they face that may be contributing to their presentation of cognitive impairment, but also the age. So this is real life. This is a real life population. You can see that about half had hypertension, high cholesterol, diabetes, cardiovascular disease, and so on, are all quite common. About 51 were heterozygous for the ApoE genotype, 13% were homozygous, 86% were treated with donepezil, 56 memantine. So a very representative sample if we think of our own clinic settings. So of the patients, of the 50 patients of the series who completed more or one of the safety MRIs following infusion, 24% had ARIAs detected. Not that far off the trials, actually. Solitary ARIA-Hs in 5, solitary ARIA-Es in 3, combined in 4. And of the 12, 9 were asymptomatic. 4 of these were homozygous for the ApoE genotype. And that's important because, of course, it is essential that we do that prior to considering medication, or that we consider all the risks around ApoE homozygosity. Of the 9 homozygous patients, 44% had evidence of ARIA. So I think that's significant. And again, this brings into the kinds of discussions we need to be having with patients and their families in terms of thinking about risk-benefit. Of the 37 who were heterozygous, 17% were diagnosed with ARIA, so a clear difference there. And then, of course, infusion reactions. Nearly 40% experienced infusion reactions after their first dose. This included headaches, shaking, chills, rigors. And 88% of the 26 patients who had side effects at the infusion center or within the first 24 hours post-infusion. And why this is important is because if we're starting to see the emergence of what we can call health tourism, in other words, people going to specialist centers, private centers to receive treatment, it's important to know where the complications might arise following treatment if they were, for example, to go home. So I'm based in Ireland, and already we've had a few patients going over to private treatment centers in the UK and thinking about what the protocols are in terms of people coming back home, flying back home, when that needs to happen, and what the facilities are in place and the shared care protocols to manage potential reactions. Okay, so let's think a little bit more closer to home now, the Irish and the UK context. I have 3 key questions in terms of implementing the DMTs in real life. The first is, how many people will be offered the drug? The next, what does the system need to do to implement these drugs? Now, we all know what they involve, but actually, how do we upscale? How do we think about this? And the last question, does everybody really want these drugs? Now, a few years ago, when the possibility of getting a license for a disease-modifying therapy was being posed or being raised, the assumption was that everybody would be wanting them. But actually, is that the case? Considering what we would consider a modest effect efficacy profile in the context of potentially significant side effects, we need to think carefully about the risk-benefit balance and what patients and families really want. So it isn't a given that when the opportunity arises, patients will necessarily want the drugs. So we've asked those questions. So let me start with this one. How many people will be eligible? Now, one very crude way is to simply look at the number of people with incident prodromal Alzheimer's disease in the mild stage or in the MCI stage, and you can crudely estimate about 10% of the annual prevalence figure per annum. But what you need to also consider is that the population is aging, so we have to consider an additional 3% per annual incidence. Now that's doing it very crudely. Let me show you a flow chart of thinking about this a little bit more systematically. And this is one way you can do it and how we've looked at it in Ireland. So moving simply beyond looking at your prevalence of MCI or early Alzheimer's disease, the first thing you need to consider is what is your prevalence of dementia overall, but based on your different age groups. And that is important. So it's not simply your overall prevalence, but depending on what your age group is. The next thing you need to do is, of that proportion, which of them actually come to the system? Because if you're trying to cost about what your impact will be, you need to realize that in some cases, fewer than 40% of people will present. We're aiming for 60, 65 plus in terms of the number of people presenting to services, but that tends to be in urban regions. Again, considering that equity issue. The next issue is about, of those who do present, what is the actual diagnosis of Alzheimer's disease based on biomarker positivity? And that brings us to the next question. And this will depend, again, on the age groups. So if you really want to try to tot up the numbers, you've got to consider very carefully what your prevalence and incidence figures are within these 10-year age group brackets. So this is a flow chart that one can do for mild dementia, but then it has to be repeated for mild cognitive impairment secondary to Alzheimer's disease, if we're thinking about the populations that will be captured by these drugs. Taking this one step further, I'm now going to draw your attention to this article here, which has come out in a special issue of the British Journal of Psychiatry, which I don't know if you can see, but I've actually got the hard copy here on my desk. And this special issue came out in June of this year, and it was called the themed issue, Pathway to Delivery of Dementia Disease Modification. So there's a number of interesting articles in there if you want to read a little bit more. But I'll take you through this paper, because I think this can give us some idea as well. Now, I realize that this schematic on the side is difficult to read, but you can take a look within the article. And essentially what the authors did was to estimate the scale of the real world demand within the UK. And they used anonymized patient records from 2 NHS services for the year 2019, collecting a range of data, and they then applied the eligibility criteria for the treatment. In other words, the eligibility criteria that we know from the clinical trials. Because if we look at what's called appropriate use criteria, in other words, who should actually get these drugs, we need to be following the clinical trial evidence at this stage. And they were able to come up with this number of people who referred to services covering around 2.2 million. Then applying the trial criteria, they estimated a maximum of 906 people per year would start treatment with monoclonal antibodies in these 2 services, which then equated to 30,000 people if extrapolated nationally. So that gives us a sense of kind of the starting point. But again, we need to take in a lot more into consideration in terms of accessibility, availability, and patient preference. So let me now turn to the second question. What does the system need to do to implement these drugs? And this is a very different story in different health jurisdictions. So where I work in Ireland now, most memory services are led by medicine of the elderly or medical gerontology services, with some input from cognitive neurology and occasionally input from old age psychiatry. The point being that memory services are largely sitting within acute hospitals, which generally have access to medical services such as infusion services, being able to do lumbar punctures to get CSF and so on. In the UK, of course, as George mentioned, memory services are largely within geriatric psychiatry or old age psychiatry services, which raise challenges because very often these are not necessarily linked directly with acute medical services, providing backup infusion services and even being able to do lumbar punctures. Now, the latter point, of course, will change when we get access to plasma biomarkers, but the way it stands now, a significant minority of people get CSF biomarkers in the UK compared to other high-income countries. And that's a concern because it's only with biomarker positivity can you get eligibility for the drug. So I think that's really the first issue that needs to be considered. But let me now draw your attention to a couple of sort of sources of information that you may find interesting to help you think through this. The first is this paper here, which is a blueprint for a brain health clinic to detect and manage early stage cognitive decline. This is a consensus exercise that here through the Dementia Academy we developed a couple of years ago before the drugs were licensed. And basically it's to think through and plan a care pathway for this group of patients who are now the most eligible for the disease-modifying therapies. They are the group of patients whom we would broadly call MCI. And typically, these are the people who fall between the cracks. For people with clear-cut dementia, services are in place, cholinesterase inhibitors and memantine are offered, and systems can move forward and they have access to various things. For people who clearly do not have cognitive difficulties, they are discharged with a bill of health. But it's the ones with mild cognitive impairment, particularly with biomarker positive for Alzheimer's disease, who really have very few services because we don't have licensed therapies until now, and we haven't had services developed for them. So that's the point of this blueprint. And I'll just run you through it very briefly because I think it forms an important infrastructure to help us think beyond the medical management of this group of patients. It also ensures that we don't carve off a group of people who get special treatment because they have eligibility for the drugs, and the rest of the people who, for whatever reason, are not eligible because of comorbidity, preference, cost, accessibility, get neglected. And that was the kind of picture we had with vascular versus Alzheimer's disease years ago in terms of service setup in the UK. So I do think it's important. To look at this blueprint, you can access this through the Neurology Academy website, and you will be able to see it. And it walks you through the different stages of what needs to be done in terms of setting up a blueprint for this group of people. And you can see here, there's a number of different sheets in terms of information about it, but I'm going to focus on this one here, the patient journey. The patient journey, the patient flow, we felt in looking at this group of people, using certain criteria, there are three basic streams. Number one, for those of you who have a research branch, can move people into research studies, particularly around disease modification and early stage treatment. For those who are low to moderate risk, there's an intervention arm. And for those who are very high in risk, there are intervention arms, plus an additional arm in terms of medication management. So the key point being here that you have a common intervention in terms of the whole group of patients, with only a minority going off to medication management. And what these interventions are essentially is brain health management, ensuring that people who are in this very high risk or medium risk of conversion to dementia in the context of Alzheimer's disease get good brain health support and management. So I won't go through this in too much detail, other than to point out that some of the key interventions here, aside from the medication management, includes brain health advice and lifestyle modification advice, thinking about the prevention of dementia, and I'll go through those criteria in a moment, but also thinking about cognitive and brain training, for which the evidence is building. So ensuring that that's the context in which the medication management can then be instituted, I think is critical. So thinking about brain prevention, I'll just draw your attention briefly to the Lancet Commission update. Most of you will have seen this already, but it's hot off the press as of July. And essentially what we've seen is a change from the previous number of risk factors to now 14 modifiable risk factors across the life course. And although these are at a population level, I think it's important to start bringing this conversation into the clinic, recognizing, however, that at the individual level, the evidence is still wanting. So again, just to bring people up to speed, bringing people up to speed. If you remember, the first set of prevention criteria were from 2017. Then we went to 2020 with 12, and then we went into 2024 with 14. And what are some of the changes? The two new risk factors that were added included cholesterol and untreated vision loss. So the evidence now is strong enough to support these two as potentially modifiable risk factors. Also, looking at the life course approach, there have been some changes. In early life, the focus remains on education and risk with higher risk with lower educational attainment. But midlife includes hypertension, obesity, smoking, physical inactivity, and high cholesterol, at the greatest benefit preventing dementia. So this isn't necessarily our patient population, but late life is about vision loss, air pollution, and social isolation. And finally, the impact assessment is that if we address these four risk factors, we could potentially, and it's theoretical and potential, to prevent 45% of dementia cases. So I'm outlining this as really to bolster this idea that we need to be thinking holistically about brain health clinics for these early stage patients in the context of medication. Now let's shift to medication. So having built that infrastructure, making sure that all our patients have brain health advice and lifestyle modification, we need to think about actually what is necessary. So here we designed a model for how we can look at these issues, because a number of things are important. Ensuring that early diagnosis and detection is actually happening. Again, still in many regions, the majority of people present too late to services outside of the window of eligibility. Secondly, is having the access to advanced medical facilities for infusions. The majority of the population will not have access, so we need to keep that in mind. Of course, we keep talking about cost and insurance coverage. We talk about patient and carer awareness appropriately for those who are eligible, but also awareness of those who may not be eligible to manage expectations. We need to think about training in administering the new therapies, but also other things, for example, thinking about the diagnostic piece for side effects and the radiology supervision that's required. Thinking about the infrastructure for continuous treatment and monitoring. And also, what is the real world? Adverse effect monitoring, the regulatory and policy hurdles, and of course, ethical and social considerations, which need to be thought about as well. So with all of those things in mind, one of the ways to do this is to come up with a conceptual framework for health system readiness. And this is based on health system readiness for infectious disease. But I think here it can modify and apply really well because it pushes us into thinking about every step of the pathway as to what is necessary for putting this in place. And broadly speaking, this includes system hardware and system software. And all of these issues need to be considered. System hardware starts with surveillance, in other words, making sure that we are monitoring the community as a whole to bring people in early enough to have eligibility for treatment. Now, a number of years ago, there was a whole discussion about potentially screening for dementia at primary care, and there was a lot of pushback against that for a number of reasons. However, that conversation is starting to shift and will definitely shift when we have access to plasma biomarkers. The next consideration in terms of hardware is the infrastructure and the medical supplies. Again, access to infusion facilities, but also MRIs and CSF. Thinking about the workforce, who is necessary to deliver these, and thinking about communication mechanisms between all the different parts of the scheme. So the most likely scenario is a hub and spoke model. So the hub being a more advanced medical center that is able to deliver and monitor the drugs, with a spoke whereby people can receive ongoing treatment and monitoring, and also the additional pieces that are essential, like the brain health support and brain training. And how those different pieces communicate needs to be thought about. And that, of course, relates to governance and trust between the different organizations, and also between the different disciplines, and potentially even between trusts. So just going back to this, for people who are interested in more detail about how we conceptualize this in the Irish context, which is a model for a small to medium-sized healthcare ecosystem, please go back to that paper that I cited up above, and we can share that with you after the talk. And finally, to finish up for the last few minutes, the question about, does everybody actually want these drugs? So here I'll refer you to our paper in the same special issue of the British Journal of Psychiatry, looking at, within a population level, people's willingness to take the drugs. So let me talk you through how we did this. We want you to understand the acceptability of these new drugs in the general population across different age groups, so not just patient groups, their perceptions of risks and benefits, and also willingness to pay. And the way we conducted this was with a nationwide survey, giving a scenario through a video clip of what the drugs involved, including their side effect, their benefit, their side effect profile, and also the potential effectiveness and efficacy. So we had 1,000 Irish residents, again, across a range of different ages. 1/3 were in Dublin, which is representative of the population as to where people reside. 60% were female, which I think reflects our Alzheimer population. They were generally educated, mostly employed. Interestingly, that over 50% had private health insurance, because of course that will influence their decisions around this. And interestingly, 64% knew somebody with dementia. So again, hypothetically thinking about drug acceptability, does knowing someone with dementia influence your decision or not? So what did we find? The general acceptance of the disease-modifying therapies was there. However, there were concerns. So just under 50% of the public felt that these medications would be acceptable, including the ramifications on society, the taxpayer, the health system, and patients. Acceptance was slightly higher in health professionals, which was interesting. Again, probably because of greater familiarity with new treatments and the impact and the implications they have. So we then asked, what were some of the main concerns? So for the public, the fact that there was only modest efficacy, that's my alarm going, was important. For health professionals, they felt that was much more important, the fact that the efficacy was only modest. Side effects were again more important for health professionals compared to the general public, and again, reflecting greater awareness of the implications. I think the real finding that was very interesting to me was that 62% of the public felt that one of their main concerns was the distance to the center. And again, really pulling the rug out of this notion that given a drug that potentially can slow Alzheimer's, everybody would jump at it. Well, actually, that doesn't seem to be the case. In other words, what we call the hassle factor is actually very important. Will this disrupt my lifestyle if I have to go to a treatment center every couple of weeks or every month to spend many hours there, receiving an infusion, even staying overnight in a hotel or a medical center? Or, for example, if I go away to holiday to Spain every year for 3 months, will I no longer have to do that? And if that's the case, what is the potential benefit? Is it worth that degree of slowing of progression, 30% over a certain period? Not sure. So again, it's about a very nuanced conversation that needs to be had between all the stakeholders involved. So in terms of ranking what's most important for the general public, this was the most important issue, was the distance to the clinic. Cost of the drug was next. For health professionals, drug effectiveness was the most important, and the side effect profile was next. Individuals' risk of Alzheimer's disease also played into this. And I'm almost done here, but again, I found this quite interesting. In terms of the influence of socioeconomic factors on acceptability, which is thumbs up, those who were more accepting of the drugs had a higher level of education, were more informed, and were also healthcare professionals. Those who were less accepting of the drug and much more reserved in their judgment, were less educated, were being a care partner, which was very interesting. Again, one would, I think, go in with a hypothesis that being a care partner would expect you to want the drug. Being retired and also being a female health professional decreased acceptability, perhaps showing a male-female difference in perhaps level of risk accepted within the healthcare context. I'm guessing. What did not influence acceptability was knowing somebody with Alzheimer's. And that's quite interesting. Having your own family history of Alzheimer's and also perceived understanding of the treatments. So there was some qualitative feedback, again, just really, I'm going through this very quickly, reinforcing some of the issues that the quantitative data found. But equity, I think, continues to be an important concern about who does get the drug and who doesn't. And I'm going to finish there and now open up for questions in the last few minutes. George, can we pass the first question to you? I can read it out so everybody can see.
Yeah. Sorry, go.
Okay, perfect. For ARIA, how frequently the patient should be scanned or imaged? Do they need lifelong imaging surveillance? Now, that's an interesting question, an important one in terms of thinking about the cost of the number of scans people need to have. George, are you happy to make a stab at that?
Yeah, just to remember back to the trial, I think it was 3 monthly, if I'm remembering that right from the trial data. But I think it was during the while the treatment was being delivered. Obviously, but Ira, correct me if I'm wrong. I think I remember that right there.
I think generally, I mean, if you're looking at the cost estimates, which really I think what the question is looking at, you know, most people would have about 3 to 5 scans during the course of treatment. So, you know, for us in Ireland, that's a huge challenge because in the public system, we might wait sometimes 6 months to get a diagnostic MRI. And again, that's to do with availability and hardware. And if then we have to add those surveillance monitoring MRIs, that is a significant added burden. So the short answer is absolutely not lifelong. It's only during the treatment period. And that also depends on the drug. And again, how long the drug will be given for is still up for debate, although based on what we've seen of the more recent trials, if we're looking at the impact of amyloid clearance, we're looking at 12 to 18 months. So I think giving that endpoint is very helpful because, again, we can estimate the costs and the impact on the system and the entire infrastructure, if that makes sense. Next question. Should I just read it out?
Yeah, or I can read it out if you want.
Okay, perfect.
We had the other potential issues for having a homogeneous population involved in these studies, 96% Caucasian, for example. Should we try and seek out diverse populations for RCTs? Absolutely, I think there are. You know, there needs to be a huge amount of sort of further data sort of coming to the fore for these drugs, looking at a sort of wider, more diverse population, and also looking at the longer term impacts of these drugs as well. Really, we've only got a very sort of short window of treatment sort of demonstrated so far, and that was one of the sort of issues sort of raised by NICE as well when looking at the approval. I don't know if you have any other thoughts on that.
Yeah, no, just to add, I think the 96% came from my slide, which was my first study that I presented about the real life. Now, that's not a trial. That's a retrospective observational cohort of people in that clinic. And it represents, who came to the clinic. But the same does apply for RCTs, absolutely. And there's a huge push, as you'll know, in terms of increasing diversity within clinical trials. And the FDA now demands that when you run a clinical trial, you are monitoring and recording a person's, in the American context, a person's ethnicity and so on to increase diversity. So not only in terms of trial results does this have importance, but I think globally the equity issue is huge. Thinking about the cost, which is why I was very intentional in terms of including the lifestyle prevention brain health elements, because ultimately that's how we're going to tackle the problem, not with expensive drugs that are targeted against single pathologies. So that's me making my pitch.
It's also of note that actually in Trailblazer, I've done about 9 out of 10 patients, and 90% of the patient cohort were white. So it is, without a doubt, there needs to be sort of further, sort of acceptability and sort of inclusion within the sort of trial going forward.
Yeah. Okay, so the next question, thanks for the comment. I'm not sure I entirely understand it, because I think we're saying exactly the same thing. Maybe you didn't like my terminology of the hassle factor. The hassle factor essentially is that people's choices may be influenced by non-health medical related considerations, because so much of our discussion is about the side effect profile, effectiveness, efficacy, cost of delivering the drug, and so on, and the infrastructure. But actually, when it comes down to making that individual choice, it's exactly the point that is being made here, that distance to the center is, trumps everything for many people, because they may have to travel 2 to 3 hours to a treatment center and then have to, hang around monitoring for side effects, maybe even a hotel stay overnight. Not to mention the example I gave, many people go away for months at a time to a hot country, and that's very important for their lifestyle and quality of life. So what you gain by taking the drug, you lose in your lifestyle in some cases. And that's really the point I was trying to make. And ultimately, it comes down to a very careful and nuanced discussion between the patient, their family, the treatment team, and also primary care, and how that's going to play out. And it's not going to be a straightforward issue of, efficacy and side effects. Okay, so we're at time now. How long does it take ApoE4 results to be available? I don't know in the UK, I'm sorry, I'm in the Irish context, and George doesn't either know anyway. If anybody knows, pop it into the chat. So we're going to have to end it there. Thanks very much, everybody. We don't want to keep you any longer. So all the best, and thank you for your attendance.